Hello, everyone. I'd like to introduce myself. My name is Jacqueline Cristini. I am a physician assistant and associate director of the Parkinson's Disease and Movement Disorder Center at Robert Wood Johnson Barnabas Health. I'm going to give you a presentation of the evolution and revolution of deep brain stimulation surgery. I'm not going to go through a complete Parkinson's disease presentation because I'm going to assume that you're familiar with diagnosing Parkinson's disease. And if there are any questions, we can address those later on. So deep brain stimulation and the cutting edge technology is very important, and it's been around. Deep brain stimulation has been around for quite some time. And I'm going to go through the slides and you let me know if you have any questions, or go through Sharon and let her know. So let's get started. So what is DBS? So DBS, of course, is the acronym for Deep Brain Stimulation. And as you can see from this depiction, there's an area in the brain, the midbrain, that controls the globus pallidus, or the midbrain area that actually controls the motor symptoms of Parkinson's disease. And we will go into the specific anatomical target sites as we go on. So deep brain DBS surgery is an effective long-term treatment for movement disorders, essential tremor, Parkinson's disease, and dystonia. The efficacy and safety depend on the spatial restriction of the stimulation field to a functional target responsible for benefit. And you'll understand that. That may sound a little wordy right now, but I think you'll understand that hopefully at the end of this presentation. Side effects emerge if the volume of tissue activated, also known as VTA, spreads into adjacent brain structures. And again, I think this will all become clear by the end of the presentation. So it is effective. It is a neurosurgical procedure, and it involves the implantation of electrodes into specific brain targets to deliver constant or intermittent electricity from an implanted battery. Very similar, the best analogy I can make is a cardiac pacemaker. It's more like a brain pacemaker. It works in pretty much the same way. The clinical use of DBS is one of the most significant developments in the past 25 years. It can measure pathological brain activity and deliver adjustable stimulation for therapeutic benefit. It intervenes directly in pathological neural circuits and has altered the way brain disorders are understood and treated. Again, I know it sounds like a mouthful, and I will hopefully, this will all be very clear by the end of the presentation. So just to give you an idea of how long DBS has been around, and how important it is to educate providers on the availability of DBS. In 1997, the FDA approved it for the thalamus for the treatment of a tremor. In 2002, it was approved for the treatment of Parkinson's disease, although different targets in the brain. And in 2003, it was approved for the treatment of dystonia and or Parkinson's disease. It is not a new therapy or a last resort. And I think the take-home message from this presentation is to just give you a very brief overview of what DBS is, and the fact that we've lost many patients that could have been helped simply due to lack of understanding, uh, not being aware that this is a very safe and effective procedure. Yes, it is brain surgery, but we're not altering anything in the brain. There's no, as in the past, there were surgical procedures that actually destroyed brain tissue to achieve a symptomatic therapy. We don't have to do that with deep brain stimulation. And I've had many, many patients come through my clinic that would have been candidates maybe 10 years ago or even 5 years ago. But due to the fact that they were not aware of it, either because their families didn't know about it, they didn't know about it, or more importantly, their providers didn't know about it. And that's not just primary care providers we're talking about neurological, general neurological practices that see many of these patients. And in particular, patients with essential tremor, they are missed many, many times and languish in primary care for quite a long time before they finally get to a movement disorder specialist. So how did we get here? So I'm not going to go through every one of these, but just to give you a bit of background, the treatment for various movement disorders was surgical lesioning. Prior to the electrical stimulation, which was really kind of discovered back in 1949. Benabid, a French neurosurgeon, is the one that really reported DBS and the benefits of it in the ventralis, the ventral medius, ventralis intermedius, because of using this electricity and seeing the results of it. So going down to 2000, they used DBS to inactivate the STN in patients with Parkinson's disease. Then 1996, 2000, 2003, it was approved for dystonia under a humanitarian device exemption. So deep brain stimulation mechanisms, to be honest, there aren't too many people that can tell you, even the experts, exactly how it works, other than it does change the electrochemical field. So as you can see, this is an electrode. This is what's implanted, and these, of course, the neurons. Goes to the neurotransmitter. We're talking about dopamine as always, and the presynaptic and postsynaptic clefts where the dopamine is being transported, or yes, being transported. I guess that's the best word I can think of for this. So the DBS interrupts that. And what the rule of thumb is generally in clinical practice is when the symptoms are whatever benefit patients are receiving from medications, such as dopamine, and then they have to, that is for us. So I'm not sure if I gave you a decent explanation of this slide, but I just wanted to kind of give you an overview of what's going on with an electrode in deep brain stimulation. And we'll go into that again a little bit later on. So just briefly, I think it's important that we just do an overview of Parkinson's disease and the epidemiology. So it is the second most common neurodegenerative disease after Alzheimer's. It affects 1% of the population over age 65. 4 to 10 are young onset. 4 to 10% are young onset. Diagnosed prior to the age of 40. It actually was the age of 50, and it may still be for some centers, but I see a number of patients, quite a number of patients, that are symptomatic before the age of 40. Again, it's not that, sometimes at that age, it's not that easy to diagnose. A lot of things are missed. In the United States, 500,000 people are diagnosed with Parkinson's disease, and it's predicted to triple over the next 50 years. And that's quite, I think, a pretty accurate number or prediction. So there are a couple of reasons why that would happen. One is, of course, people are living a lot longer, and the average age of diagnosis is 65. But as I said, I diagnosed many, many people younger than that, and many people in their 80s. Now, of course, people in both of those age groups have a totally different lifestyle and goals, but nevertheless, 65 years of age today is not considered elderly by any stretch of the imagination. And the fact that we're diagnosing people sooner and younger is one of the reasons why these numbers are really tripling. And it is slightly more common in men than in women. So diagnosing it, pretty much, it is a clinical diagnosis. I'd say 95% of my patients I diagnose clinically. If I'm not sure, I'll get a DAT scan. You know, it's based on signs and symptoms. And if you see PD patients day in and day out, as I do in clinic, it's pretty hard to miss the signs, even if they are subtle. If I'm unsure, so if a patient comes in with a tremor that may not be a classic typical tremor at rest, which is what we see in Parkinson's disease, but they may have had or may have been diagnosed with essential tremor years ago. And not unusual for initial diagnosis to be essential tremor, and then years down the road, other symptoms emerge, such as slowness or stiffness. And we're now looking at not essential tremor, but a Parkinsonian syndrome. So that's when I would order a DAT scan. That's one of the reasons I would order a DAT scan. Another reason is if the patient requests. So if you treat a lot of patients with Parkinson's disease, particularly a young population, one of the first emotional, psychological things they go through is denial. You're telling somebody in their 40s that have young children and have a full-time job that they have Parkinson's disease. Many of them just don't accept it. And that's certainly understandable. So I will offer to get a DAT scan for them because I think that may help them cope with it. And again, is it essential tremor or is it a tremor due to Parkinsonian syndrome? So DAT scan is a very useful visual adjunct imaging modality that we have. So the pharmacotherapy. Levodopa remains the mainstay of Parkinson's disease therapy. And that is, good and bad. It's good in that it still works very well if we are dealing with idiopathic Parkinson's disease, the most common form, and approximately 85% of patients are diagnosed with idiopathic. And if it is idiopathic, the robust response is typical, and a reduction in motor symptoms pretty much confirms a diagnosis, although I would never use that as a diagnostic tool. Many neurologists I have better patients that have come to me have said, well, the doctor said, here's a script for Sitamet, take this, if your symptoms get better, you have Parkinson's disease. So motor complications frequently emerge over time from levodopa. And I think we're all familiar with the motor complications, dyskinesia, motor fluctuations. So I think this is a very important slide because in early Parkinson's disease, and hopefully you get to see patients earlier rather than later, we start levodopa. Typical starting dose is 1 tablet 3 times a day. Carbidopa, levodopa. For those of you that haven't used Sinemet for many, I've used it for over 15 years. So to me, I still use Sinemet, even though that was the proprietary name for it. So in early Parkinson's disease, your dyskinesia threshold is kind of low. The response is pretty good. As you move into a more moderate stage, as you can see, the levodopa, the therapeutic window gets narrower. Your dyskinesia threshold is changing, and you have to treat the patient with more medication, either more Sinemet or polypharmacy, which is the kind of the rule of thumb in Parkinson's disease. Rarely does a patient stay on one medication for a very long time. So when it's advanced, as you can see, you get very, very little benefit. You're still getting benefit, but that window has gotten much, much narrower. So your response threshold has changed, as has your dyskinesia, if you go from early to advanced. So when it comes to DBS, we like to offer the surgery to patients in early stages or moderate, never advanced, because honestly, when it's advanced, symptoms become less responsive to dopamine and therefore less responsive to deep brain stimulation, because the rule of thumb is, well, if their symptoms are responsive to levodopa, then they are certainly going to be responsive to deep brain stimulation. So I just want to touch on the atypical forms of Parkinsonism. So PD, idiopathic Parkinson's disease, they are appropriate candidates for deep brain stimulation. Who are not appropriate candidates? Unfortunately, MSA or multiple system atrophy, those diagnosed with progressive supranuclear palsy, or cortical basal degeneration, or any of the other forms of atypical Parkinsonism, such as vascular Parkinsonism, lower body Parkinsonism. None of those patients would be appropriate candidates. Idiopathic Parkinson's disease, dopamine responsive symptoms, those are the candidates. All of these forms of Parkinsonism are associated with dopaminergic neurodegeneration, but not all of them respond to dopamine therapy. They may respond initially. You may see some symptomatic relief, but that usually wanes rather quickly. So atypical Parkinsonism, PSP, or progressive supranuclear palsy. Sometimes it's difficult to diagnose. Characteristic symptoms may develop late or not at all. So one of the things that is really I think the dead giveaway in PSP is when a patient comes in and they're having falls and really no explanation as to why they're falling. Their personality changes. They have dysarthria, dysphagia, cognitive changes, and a lot of them have the inability to maintain eye contact. But the unexplained falls is, something you really need to investigate. Idiopathic Parkinson's disease, you will not see that. And usually gait changes and gait disorders will occur at later stages. They don't happen in the beginning. And when you get an MRI, you're going to find on PSP midbrain atrophy. And I have a couple of slides I'll show you. So gait and balance, frequent falls So their gait is stiff, broad-based, with an extension of the knees, trunk, and neck, also known as the Frankenstein gait. So it's certainly not your typical Parkinsonian gait, which is shuffling. They have stooped posture, totally different gait. These patients, they'll be looking up because they have lost the ability to, they have paralysis of the down gaze or ophthalmoparesis. So in order for them to see down, they need to move their head up, also known as doll's eye maneuver. So that's the most striking sign that you will see in PSP, and they have lack of insight. And again, it goes back to the cognitive impairment. A lot of them, when you ask them why they're falling, they can't tell you, but they'll forget. They'll keep getting up because they don't realize when they get up, they're going to fall. So the big problem with PSP is fall risk and injuries. Pseudobulbar effect, so unprovoked crying, unprovoked laughing, depression, and again, dysarthria. Their speech is usually dysarthric or will become dysarthric, and they have a lot of trouble swallowing. So if you look at an MRI, what you can look for is the Hummingbird sign. Now, here's the Hummingbird sign. As you can see, there's atrophy of the midbrain, and it certainly looks like a hummingbird. There's the beak, and the pons is kind of flattened. And if you look at the cerebella, it certainly doesn't, when you compare it to a normal brain, which I think is always helpful when you're looking at MRIs and looking for something and not sure what you're going to find. This is a normal midbrain and cerebellum, and of course here. So Hummingbird sign is one of the things that we look for on MRI in patients that we're diagnosing with PSP. So another pretty common atypical Parkinsonism is multiple system atrophy, or MSA. Now, there is a pretty easy criteria for diagnosing this, and one of the most important is autonomic nervous system failure. So when patients come in with, of course, they'll have motor symptoms, but they'll have orthostatic syncope. Not almost always, every patient I have ever seen has had orthostasis and orthostatic syncope. Impotence, bladder dysfunction, motor control symptoms. They can have tremor, rigidity, loss of muscle coordination. But you're not going to see the typical Parkinsonian asymmetric symptoms. It affects both men and women, primarily in their 50s. And again, loss of nerve cells in the brain and spinal cord, and a buildup of protein alpha-synuclein in dopamine producing cells. And all of these forms of Parkinsonism are all alpha-synucleinopathies. And that's where a lot of the research now is based as far as treatment. They are targeting the protein alpha-synuclein and the unfolding of that. And hopefully, I mean, the research is pretty promising about right now we treat symptoms. But the goal of the research for alpha-synucleinopathies, excuse me, is to try to prevent that from continuing. So can we, is it a diagnostic tool? No. Is it a symptomatic tool? Yes, in that it may be able to help slow down the progression or modify the disease, which we do not have right now. There's no disease modification therapies available. So on MSA, if you're looking for an MRI, you're going to look for a hot crossbun sign. And again, It's a cruciform hyperintensity in the atrophied pons. So you could see it very clearly on this MRI. And as you can see, this is a normal, what a normal looks like, the normal midbrain. So hot cross bun sign for MSA, hummingbird sign for PSP. So vascular Parkinsonism, 2.5 to 5% of all cases of Parkinsonism. See more of this in the older population. Biggest risk factor, of course, is cerebrovascular disease, diabetes, heart disease, strokes. It's also called multi-infarct Parkinsonism or lower body Parkinsonism. These patients don't always have their typical, again, typical symptoms. It's usually postural instability, falls, their gait is short-stepped, wide-based. They may have lead pipe rigidity. They don't really have a resting tremor per se. Parkinson, the gait is more of a Parkinsonian ataxic gait, not the slow, shuffling, festinating gait. And the response to levodopa is poor, as are any of these atypical Parkinsonism. So what you'll usually see in the MRI is diffuse white matter changes due to the cardiovascular history. Another one, cortical basal degeneration. Most common cognitive abnormalities in cortical basal degeneration were executive and visuospatial dysfunction. Dementia is now recognized as a presenting and predominant feature in many cases of cortical basal degeneration or CBD. I apologize for the CBS, it's not CBS, it is CBD. So alien limb phenomenon, including complex unintentional, I have a fly around there, sorry, unintentional limb movements that interfere with normal tasks. So if you've never seen a patient with alien limb phenomena, it's pretty interesting. They will not know, for instance, what their hand is doing. It doesn't even feel like their arm is attached to their body. It will move on its own. You can do certain maneuvers with them and ask them to, let me see how you would brush your teeth. And they really can't do it with the limb that is affected. It's as if the limb has a control of its own, and it's not in control. The patient has no control over it. So it's a pretty interesting phenomenon. Thankfully, we don't see it that often. And okay, so now to get into the meat of this presentation, which is deep brain stimulation. So deep brain stimulation, as I said in the beginning, there are appropriate candidates for it, and those would be idiopathic Parkinson's disease, essential tremor, and dystonia. So just to give you a kind of brief overview of it, for over the past 25 years, so it has been around that long, it has become the standard of care for patients with treatment refractory motor circuit disorders, most commonly Parkinson's disease, dystonia, and essential tremor. It is highly effective at controlling motor symptoms. So just so that you can get an idea of what we're talking about, this is actually a DBS lead. It's a thin, insulated, coiled wire that is inserted into the target that is going to help control the motor symptoms. This is the extension. This is connected to the battery or impulse generator. And we have the ability of adjusting this periodically. The patient also has the ability to adjust this. It's a pacemaker-like device. It's a battery and circuitry to generate electrical signals that are targeted to structures deep within the brain. So I think, as I mentioned earlier, you don't want to miss the window of opportunity. So what do patients typically, Parkinson's patients, their typical day? They have on time and they have off time. So on time with disabling dyskinesias or other non-motor side effects. Off time characterized by disabling tremor, rigidity, or akinesia, bradykinesia. So in other words, when they're on, their symptoms are controlled, but they may have very disabling dyskinesias. And of course, dyskinesias, a lot of patients really don't understand what dyskinesia is. They think it's a symptom of Parkinson's disease, but it's actually a side effect of levodopa therapy. So it's pretty easy to explain to patients in language that they would understand. So we're giving you medication. You're taking Sinemet, and you're taking that to try to normalize your movement or your motor symptoms. And what happens if you take more than the brain can actually handle? You're moving more than you'd like to move, which is what dyskinesia is. It's just involuntary motor movements. But they don't really understand that, a lot of them, until you explain it. So off time means when, as I showed you in that slide earlier, the window of opportunity gets smaller and smaller because the benefit of the levodopa, not that it doesn't work, but it works on shorter and shorter time intervals. So we have to keep giving them more. So off time is simply their symptoms return. And a lot of patients have very unpredictable on and off motor fluctuations. So they're on, medication's working. They go off, medication stop working. For many, that's unpredictable. And that unpredictability, again, we can go into a whole talk on that, and the gastroparesis. A lot of it is due to the gastroparesis and how the medication is absorbed and what medications they are taking. And medication, Sinemet, if there is a resting tremor that is rather significant, it's pretty resistant to medication. You can throw a boatload of Sinemet at them, and you're probably not going to get that tremor under control. So the keys to success, very, very important. And I have been, involved in DBS for over 15 years. The technology and the technological advances have been pretty incredible. So the keys to success, patient selection. So what do we mean by patient selection? As I said earlier, idiopathic Parkinson's disease, essential tremor, dystonia. If the patient has, or you suspect that it is not idiopathic Parkinson's disease, but an atypical Parkinsonism and a poor response to dopamine, then they are probably very likely not a candidate for deep brain stimulation. And I'll get into how we kind of try to establish a criteria where we can kind of make sure that when we select a patient for the surgery, they're going to have a good outcome, and they're going to have the benefits of motor symptom control. So the precision of electrode targeting. So what do we mean by that? That means that you have a neurosurgeon that is a functional neurosurgeon that is very experienced with DBS, knows exactly through imaging where we want to place those electrodes, and gets those electrodes in the exact place that they should be. And I'll go into that a little bit more. And also someone, so that's key. These are very key keys to success, and experience stimulation and medication adjustments. So you want someone that has been, that is very familiar with deep brain stimulation programming and also medication adjustments. So, the goal of DBS is to improve quality of life for people. So their quality of life is quite diminished when they're taking a medication every 2 to 3 hours of the day. And they don't sleep because they have to keep taking medication, and they're having adverse side effects from the medication. They really don't have a good quality of life. So they hopefully, after surgery, and with adjustments of the stimulation, we can significantly lower their doses of medication, thereby improving their quality of life and controlling the side effects. So a lot of them do have medication side effects, adverse effects. And once we get the deep brain stimulation, we have a sweet spot in the brain, we're getting control of their motor symptoms, we slowly start to adjust the medications and wean them down. Rarely do patients come off of medications completely. Some do, but usually we get them down to a dose of medication that is manageable and that is not causing side effects. And they're no longer having these motor fluctuations of on and off all day long, because now they're on 24/7. DBS is on all of the time, unless they turn it off. So the technological advances that have been made over the past, I'm going to say over the past 5 years, have been incredible. Okay, so the technological advances. So I'm going to tell you that for the past 15 years, I have been involved in deep brain stimulation and deep brain stimulation programming. So there have been quite a number of really great technological innovations. So the only company in the past that even made the medical devices was Medtronic. And it worked, but they kind of didn't have any competition. So without competition, there's no reason to be more innovative. And then what happened was another company, Abbott, came out with their deep brain stimulation device, and it was better than Medtronic. It offered more programming. It allowed programmers to have more flexibility, thereby giving the patients better control. So the electrode designs now allow, and I'll kind of go into this later, you'll get a better understanding of it, will now allow programming to direct the current flow in vertical and horizontal planes. There are more programming options to compensate for a small deviation. So what we mean by a small deviation from the optimal target, so as I said, if you have a very good, very experienced, functional neurosurgeon and gets that electrode exactly where we want it in the target that we want to get it in, you're going to get a good outcome. But many times you have a deviation from that for many reasons, but regardless of how good your neurosurgeon is. And if that happens, well, we may achieve our goal, which is to control symptoms, but having done that, we may also induce side effects. And the better technology has really made a big difference in getting symptom control without inducing side effects. So the initial settings usually need adjusting, but based on the clinical course and predominant symptoms. Complex clinical problems such as gait or speech problems may require multiple adjustments, and they do. And if you have the patients and your patient is given, and I should have put this in the keys to success, because honestly, patients must have realistic expectations. I have seen many, many patients come through my practice that have gotten DBS, from other centers because they don't have this strict criteria, and perhaps they are not, patients are referred to a neurosurgeon as opposed to a movement disorder specialist. And they're, oh yes, you have Parkinson's disease, sure. Well, yeah, this is the wonder treatment. No, it's not. It doesn't change the course progression, and it's not a miracle, and you can have side effects. And if you are not, your gait is impaired, and it is not your best on time, does not improve your gait. In other words, you take your medication, but you're still freezing and you still can't walk and you're still unbalanced. Well, DBS is not going to cure that. If patients have realistic expectations and they have a very bad tremor, and the tremor is the most troublesome symptom for them, then they're really not concerned with the gait. As long as you make all of these things very clear to them, then their expectations are realistic and they're happy with the surgery. Speech today is not a big problem because of the advances, technological advances that we've had in the past 5 years. So how will the technological innovations in DBS programming change patient outcomes? Okay, so if you're not experienced in DBS programming, I know a lot of this might not make a lot of sense to you, and I'll hopefully show you a couple of slides that will clarify it a little bit better. But the newer contact designs now allow us to steer the stimulation. So in other words, we can, in the past, we had cylindrical contacts where the stimulation, even if the electrode was optimally placed, the stimulation can spread into areas that you don't want, which can lead to side effects. So, despite accurate placement, side effects may result due to unwanted neuronal stimulation. So the newer technology has now allowed us to steer the current to where we want it and away from where we don't want it, thereby avoiding many of the side effects that we used to see in the past. So patient selection for STN. So STN, sorry, I should have spelled that out, subthalamic nucleus. So earlier is better. You can read the early STIM study. It was quite a significant study done with a very large patient group. So it improves quality of life compared to best medication therapy. So medications, as we are all aware, no matter how much it's helping, there's always side effects. And the long-term effects of dopamine, giving it to patients in the pulsatile fashion that they need to take it in, the jury is still out, and maybe forever, as to does that actually do some long-term neuronal damage. So we get, you want less anti-Parkinsonian medication complications, improved social and occupational activities. Oh, I did say subthalamic nucleus. Okay. So patient selection, earlier is better. And I say that without hesitation. So the selection criteria for subthalamic nucleus versus globus pallidus interna for DBS. So idiopathic Parkinson's disease dystonia. So they've never quite, there haven't been enough studies, there really haven't been any clear-cut studies. Most of the information that we go by is anecdotal. A lot of it, but it's anecdotal. Again, idiopathic Parkinson's disease dystonia, no significant comorbidities. These are, patients that will do well. No severe depression, psychosis, or cognitive impairment. So troublesome symptoms despite optimal pharmacological management. So what does that mean? They're having on and off fluctuations. They have really bad dyskinesia, and I've seen some really bad dyskinesia, and the tremor is simply not controlled. And if you're familiar with Parkinson's disease, tremor at rest, rarely do we get very good tremor control. And the disabling side effects related to medications, again, GPI, globus, pallidus, intermedius. So either of these targets, brain targets, are appropriate for Parkinson's disease and dystonia. We usually will go with STN if patients are on a rather high dose of medication. GPI and also the STN in older patients with, they all have mild cognitive impairment. They really do. The older patients. DBS is not going to worsen that. But this target, the STN, may cause some advanced, or I wouldn't say advanced, but it may speed up the cognitive impairment. So GPI is a more judicious site for those patients. And if they're on a lower dose of medications, dopamine, GPI is also a good selection. STN allows us to drop the medications much more. GPI, we don't need to, they're not on very high doses, so we don't really need to drop it that much. So those are kind of the criteria that we'll use for selecting the site, but more often than not, it is the subthalamic nucleus, unless we're talking about a lot of dystonia. Candidate selection. So the first thing that I do is called a dopamine challenge, not applicable for patients with essential tremor. If tremor predominant, you may see minimal improvement in tremor. So what is a dopamine challenge? So a dopamine challenge, and I do it quite often, patients will be on medication, and I ask them to hold their medications for 12, 24 hours, for as long as they can. I want to see them in an off medication state. I will then do the UPDRS Part 3 motor examination and score it. And then I will ask them to, and if it's tremor predominant, I don't really pay too much attention to that as far as the on-off, because tremor is really one of those refractory symptoms that no matter how much Sinemet they take, they don't get good tremor control. So they will come in off, and then after the motor exam, they will take a little bit higher dose than they normally take. So if they're taking 2 Sinemet for symptom control, I'll ask them to take 3. We will wait until they feel like they're on, or the medication's working, and I will repeat the motor examination, and that will be their on and off. So there has to be, I have to see at least a minimal of 30% improvement in motor symptoms. I usually see a much greater improvement if they're really dopamine responsive and it's idiopathic. Again, I don't assess the tremor because that's usually refractory, and that is the one symptom that is most responsive to deep brain stimulation. The next step, if I see enough of an improvement in the on-off dopamine challenge, the next step is to do a neuropsychological evaluation. They will be sent for comprehensive neuropsychological evaluation, because we want to make sure we're not missing any, things like psychosis, dementia. Those are all red flags. Usually you can, if you know your patients, you pretty much tell that they're going to do okay in the neuropsychological evaluation, but you really should have it. I mean, I wouldn't send a patient to surgery other than ET without a neuropsychological evaluation. And then, of course, the next step after that is an MRI of the brain using a DBS protocol. I usually ask my neurosurgeon to order that. They have very specific protocols because it's used for surgical planning and targeting. So that they'll go to the neurosurgeon for that. And then we will meet as a team. We have a case conference once a month to discuss patients that have met the criteria and are considered good candidates, appropriate candidates for the surgery. And myself, the movement disorder specialist I work with, our neurosurgeon, if available, our neuropsychologist, will discuss what we think is the appropriate target for that patient, what target is going to give him the best symptomatic control, least side effects, etc. So if this is a pretty simple slide. So dyskinesia before surgery, as you can see, it's pretty high. There's the threshold. On time, after surgery, and off time. So one of the biggest benefits of DBS is that we really can control dyskinesia. If I program a patient following surgery and they become dyskinetic, that's a good sign, because that means we are right on target, we are inducing dyskinesia, and we can just as easily reduce dyskinesia. But the patient's going to get the benefit without the side effects. So they're always on. They're never off. As I said, it's rare that patients can come off medications completely, but significantly reduce the amount that they take. So talking about the anatomical targets, they haven't changed since the beginning of DBS. So the VIM of thalamus is the target that we use for essential tremor. Again, the subthalamic nucleus, and you could see how small this is. That is the site that we use for the most part for Parkinson's disease. If there's a lot of dystonia, or if it's clearly a dystonic patient, the target will be the globus pallidus interna. We sometimes use it for Parkinson's disease as well. Again, it depends on the circumstances. So challenge versus opportunity. So the advent of the directional leads is a recent technological advance and has the potential to expand the capabilities of DBS, and it has done that. The ability for us to more accurately target and precisely control stimulation can theoretically improve the effectiveness of DBS while avoiding side effects. So there's, as I said earlier, no firm clinical evidence. So much of it is anecdotal, but there have been over 120,000 patients, I think by now, that have had deep brain stimulation. So the evidence is pretty strong, but it's very hard to do clinical trials. So another thing I'd like to mention is a work versus sleep. Now, we did not have this option 10 years ago, but the advancements in neuroimaging have allowed us now to target under general anesthesia using microelectrode recordings, or MER. That's what we do in the operating room, where actually, as the electrode is being advanced into the target, we are listening through microelectrode recordings as to where it is. We can tell by the sounds and what we're seeing on the computer where we are in the brain. So it's interoperative test stimulation. So there's a sleep deep brain stimulation surgery. So it utilizes imaging in the form of intraoperative CT or MRI, and it has demonstrated reliable targeting. I have programmed patients that have had this surgery done asleep, and they've had just as good an outcome as patients that have had it when they're awake, which is really, most of them are awake. So the currently studies provide evidence that asleep is highly accurate. But again, no randomized trials comparing the two. So I think the only take-home message I can give you regarding awake versus asleep is I think a good choice for patients that do not have tremor, that have dystonia, because dystonia is a symptom that you do not realize immediate benefit from. Usually dystonia, when you program a patient, it's going to take sometimes weeks or even months to see the benefit. But if you have a patient that has a tremor, that is tremor dominant, has essential tremor, you really need to have the patient awake. The procedure itself is not painful. It's a little bit uncomfortable. I'm fortunate enough to work with a neurosurgeon that uses a frameless technique so that the patient's head is not bolted down to the operating table with a frame. So it's a little more comfortable and it's just as accurate. So I prefer, unless we're talking about dystonia, I prefer having the procedure done while the patient is awake. Also, when they're asleep, we're talking about general anesthesia, which is always a risk, especially in elderly patients. And you don't know how long they're going to be under general. When you're awake, we just use, just a small amount of propofol to when we're drilling the burr holes. You don't want the patient awake when you're drilling holes in their head. But other than that, it's better for them to be awake because we're then interacting with them. We're talking to them. We are listening to their voice. Is there any speech side effects that we're seeing on any of the settings that we're using? Because we program in the operating room. Actually, I'm in the operating room programming patients, and if I see a side effect, well, okay, well, this isn't the best target. Let's move it. So I think awake has a lot of really good benefits. So the imaging has made tremendous progress in recent years. We can actually see where the subthalamic nucleus is much, much better. So we merge the MR and the CT, high resolution imaging fusion, and it has improved the visualization of the targets for stereotactic planning. And that is really the key to getting the electrode precisely where you want it. So, I mean, the advances have been just really incredible. So let's talk about the accuracy. So as good as the imaging is, brain shift occurs. There's no getting away from it. You put a burr hole in someone's cranium, you're gonna have a CSF leak. It just happens. There's no avoiding it. What we used to see in the past was, well, we were targeting, this is the target, but due to pneumocephalus, the target is moved. And then 3 to 14 days post-op, well, this is the brain after the pneumocephalus has resolved, and the target perhaps wasn't where we wanted it. So using microelectrode recording in the operating room really helps us to avoid the movement of the electrode from the target. And of course, the more accurate we are, the quicker we're in and out of those burr holes, the less pneumocephalus you have. But it usually resolves quite quickly. But again, we do O-arm fluoroscopy following the procedure before everything is finished, just to make sure, okay, is the electrode where we wanted it? So that's something you have to think about. So this is just, I thought maybe you'd like to see what the imaging looks like. This is an O-arm, which we do following the insertion of the electrodes, post-op MRI and CT scan. This is bilateral subthalamic nucleus, and again, tremor dominant Parkinson's disease. So these are just some images of where the target is and what it looks like when the electrode is placed. And one of the things I think that's important to mention is that the worst, and patients ask me all this time, well, what's the worst thing that can happen? Well, of course, that's something I'd rather they discuss with the neurosurgeon. I mean, of course, you can have hemorrhage, you can have death, you can have paralysis, you can have any of those things that you'd have with brain surgery, although I've never, thank God, seen that in any of my patients. But you need to let them know that, okay, from my point of view, the worst thing that can happen following surgery is it doesn't work. Yeah, no, that's not a great thing. That's quite rare. But you're not ablating tissue. It's not surgery that's going to change your brain in any way that you're going to alter something that's permanent. If it doesn't work, you have an electrode. It can be removed or it can remain, but you haven't done anything permanent to the brain. And I think that's a very important thing to let patients know. So we were talking about the advances in the technology. So just very simply, this is what the electrodes now look like. Before, they all looked like that. So now we have segmented contacts, and these are usually the contacts that you really want to get into the precise target. I mean, any of them will work, but this tells us that these are really the sweet spots. So to try to give you a better idea, so these are the companies. This is one of the companies, Boston Scientific, their system. Theirs is they were the third company to come out after Abbott. So they come equipped with Bluetooth connectivity for greater data transfer, longer telemetry, and unencumbered DBS programming. It happens to be one of my favorites, to be honest with you. The rechargeable batteries offer a lifespan of at least 15 years. So in other words, the older systems, we did have a rechargeable. Medtronic had a rechargeable battery, but it was huge. For patients to recharge it, it was rather cumbersome. And they got, I think the lifespan was 9 years. This battery is much, much smaller, and you get 15 years out of it. And on average, a patient has to sit down once a week for an hour to recharge it. This is a patient programmer. So I can, when I program a patient, give them certain parameters that they can change. They can switch to different programs. If they leave and they're feeling fine, their symptoms are gone, and then 2 days later, oh gee, my tremor came back. Okay, so why don't I try this other program, or let me increase my amplitude a little bit. And this is the wireless charging system. And again, they about 1 hour a week. So it's really not cumbersome for patients to recharge, and the battery will last 15 years. This is the Abbott system. They kind of blew Medtronic out of the water when they came out with their system. And I have nothing against their system. I love their system. I've been using it for a very long time, since they came out with it. They had the first directional leads. And what they have now is really quite innovative. The patients can actually download the app onto their smartphone to give them the ability to make the changes that we can give them. And it allows virtual programming. They're the only company that has FDA approval for virtual programming. So what's the benefit of that? The benefit of that is I have patients that travel from go down to Florida or go to Arizona. They're snowbirds during the winter, and they can't always have access, or they don't always have access to someone that's moving toward a center or someone that's experienced in programming. So they can just call and say, listen, I need you to check my system, and we can get online and I can virtually do that. Their only downfall right now is they don't have a rechargeable, but it's an excellent system, and I've used it quite a number of times. So it's again, the choice depends on the patient's lifestyle. So Medtronic, who was, like I said, the 500-pound gorilla in the room for many years, finally caught up with the other two companies. So they have come out with a directional lead just a couple of months ago, and something called SureTune, or it says, it allows us to, as you can see, it's got brain anatomy here. So it allows us to, as programmers, to get a better idea of exactly where the electrodes are. And they also, the patient has the ability to turn on something called Sensite. So that can sense, and it's kind of good because a lot of times, we don't know when patients, they're not good historians as to when they're on, when they're off, when the symptoms started, when they stopped. Was it when they took medication? Did it benefit them? So with the Sensite, that the patient can turn that on, leave it on for a week or two, come into the office. We can download that information and know exactly when they're through beta waves in the brain, when their symptoms occurred, when they resolved, when they took their medication, and what effect that had. So it's pretty intuitive. It's the only DBS system with sensing, directionality, and visual programming. So they've really stepped their game up. So they're all very, very good systems. And the first of its kind sensing-enabled directional leads with the directionality plus the power of sensing. So I have used it, and I'm very pleased with it, and it's helped the patients. So again, the improved technology. So this was what all the full ring contact. In the past, every contact and each electrode has 4 contact points. In the past, they were all full ring. Now, they each have segmented contacts. So that, again, when I was talking about steering current away from something that an area that might cause side effects, that's what this allows us to do. And it's made quite a difference in programming. So the stimulation of single lead segments may result in improved therapeutic window. The threshold for achieving therapeutic benefit may be lower with the optimal direction stimulation. In other words, this segmented lead is using less energy to get the same effect, and less energy equals longer battery life. So to obtain optimal clinical effect, certain parameters have been determined empirically. As I said, it is empirical, it's anecdotal, but it works. So typical side effects, and again, we don't see a lot of this now, and we're able to better control it. Most of them result from current spreading into brain regions bordering the target that we're putting the lead in. So the subthalamic nucleus is small, ovoid structure, and it's close to the internal capsule, substantia nigra, red nucleus, third cranial nerves. So if your stimulation is spreading into any of these areas, you're going to get side effects. Simple as that. So reports suggest that the most effective contacts to relieve Parkinson's disease symptoms are in the dorsal lateral sensory motor aspect of the STN. Very easily said, not that easily targeted, because the STN is just a small bunch of neurons. So we're talking about millimeters here. So yeah, that is the optimal target, technically, if we can get it there. That's very precise, very tiny. So the typical side effects that we would see is spastic muscle contractions, most commonly facial pulling. So you'd see a patient, you'd get onto a certain thing, and so that's what we would see. And that's simply because the current is spreading into the internal capsule, which is lateral and anterior to the STN. Sometimes gaze deviation, although I haven't had a whole lot of that. Paresthesia, they're stimulating more medially. It's usually transient, but if it's persistent, the dorsal contact may be better. So this is kind of getting into the programming aspects. Speech impairment, we don't see that as much anymore. Dyskinesia, as I said before, it usually indicates a good outcome, an electrode placement. So if I see a patient, if I'm inducing dyskinesia, I'm like, yes, good. Okay, so let's just lower that. That means we're getting benefit, and we can alter the stimulation, and we can also probably in all likelihood lower their medications, because what induced dyskinesia for them before? Too much dopamine. So gait impairment and postural instability, it may get better, it may get worse. We never tell a patient that their gait is going to get better or it's going to get worse, because we don't know. But again, with the newer technology, a lot of the programming that may have caused some gait impairment, we're now able to better control. So we're seeing less of that. So the parameters, there are general guidelines available, but no clear validated and established programming protocols. The electrical field delivered through the contact is spherical, with intensity of field decreasing in proportion to distance from the electrode. I don't want to get too much into this because it's really all programming. And if you're not familiar with programming, it won't mean a whole lot other than the directional lead technology. I think that's the take-home point, makes it possible to steer different shapes of current at the stimulation contact instead of the conventional spherical shape of current. It permits the steering of current to the desired areas and avoids the unintended areas. So if you just take a quick look, this is a simple diagram, but I think it kind of gives you an idea. That's a monopolar or single. So that's one of the contact points. As I said, there's 4. This is just a negative cathode, single negative. This is negative. The IPG is positive, or the battery is positive. So it's the energy is going here. Double monopolar means that we're just using 2 contacts. And bipolar means I'm trying to limit the spread. So I'm making this, instead of the battery being positive, I'm making the contact positive, thereby limiting the spread. That's what we had to do in the past. We don't really have to do that very much now because of the directional leads. And that's a single positive anode contact. And again, so this, I think, is probably a really nice graphic. So here's our 4 contact points. So when you get your electrode where you want it, and this is a cross-section of the electrode, you want to get it in the sweet spot, and they're showing dorsolateral. This is where your current flow will be, and this is the sour spot. So in other words, this is an area you don't want to activate, because that may induce side effects. So here's a directional. Now they're showing you the newer directional or segmented leads. So instead of having 100% of your stimulation in this area, you now have 33, 33, and 33. So you can use just one of these. If this is your sweet spot and that's giving you your benefit and you want to avoid this, well, then you try the different segments. And as you can see in the last depiction here, we're getting all of the benefit and none of the side effect, because you can see the shape now of the stimulation. It's not spherical, it's directional. So we are avoiding this, and we're getting all of our stimulation or volume of tissue activated exactly where we want it. I hope that's a helpful slide. So again, the correct selection criteria for ventralis intermedius, essential tremor. It's the most common form of tremor, involuntary, rhythmic muscle contraction, it's a common movement disorder, and it usually affects the hands, but it can occur in arms, head, vocal cords, torso, and legs, may be intermittent or constant, and generally affects men and women equally. And these are, sadly, these are the patients that I have found through the years that languish in primary care and in general neurology because they're all given the same medication, primidone, propranolol, And yeah, it may help for a little while, but the tremor is going to progress and those medications become less and less effective. And DBS is just, has been such a game changer for these patients. It's almost becoming the gold standard. And it's so sad that it's not, the awareness is not there. So the clinical criteria definitely is an essential tremor. So postural tremor of moderate amplitude is present in at least one arm. And again, the difference between essential tremor and Parkinsonian tremor is usually a tremor at rest and it's asymmetrical. Essential tremor, you'll see more of a symmetrical pattern. And it occurs a lot of times as a family history, it occurs earlier in life. And it's present in at least one arm during at least 4 tasks: pouring water, using a spoon to drink water, drinking water, finger to nose movements, drawing spiral. So these are all things that I put patients through when I am diagnosing their essential tremor, and I rate each of these. And of course, the Archimedes spiral, you'll see essential tremor is never a symmetrical tremor. It's not round. It's usually, it's longer. And this is just a Archimedes spiral of a, someone without tremor. Parkinsonian tremor would be more spherical than an essential tremor when you ask them to do a spiral. And if it's bad, this is actually, I would rate this probably a 2 out of 4, 0 being normal, 4 being the worst. I mean, I've had patients, many patients, I can't even hold a pen to the paper in order to do a spiral. So here, Parkinsonian tremor, as you can see, it's not tremulous, it's small. The longer they go, the smaller it gets. And this is an essential tremor. And that's pretty typical. So these are the things that I usually, these are the steps I go through when I'm diagnosing patients. So pharmacological treatment, it remains unsatisfactory. And of course, our 2 go-to medications are propranolol and primidone. There are others, but if these don't work, chances are you're not going to see a whole lot of benefit with any of the other medications. So the most common involuntary movement disorder seen in clinical practice, which is true. The differential diagnosis is mainly clinical, based on the distinction at rest, postural, intention, activation, and frequency. The essential tremor and the tremor of Parkinson's disease are the most common tremors encountered in clinical practice. Action tremor includes postural, isometric, and kinetic, and it's usually bilateral. So looking ahead, the challenges: meeting the needs of an aging population and expand indications for DBS, including depression and Alzheimer's disease. They are using DBS in a lot of neurological disorders. There's a lot of clinical testing going, I should say clinical trials going on. Trying to find the biomarkers that are going to predict clinical response, the stimulation parameter settings, and early intervention is more beneficial than late. When dopamine doesn't work, DBS isn't going to work. So give your patients the benefit. So the other indications, epilepsy, Huntington's disease, they're using it for epilepsy now, and OCD, major depression, and bipolar disorder. Of course, these are all at large centers under study. They've had a lot of success with Tourette syndrome, and they're now studying the benefits in Alzheimer's disease. Again, another alpha-synucleinopathy. So key points. There's no benefit in waiting. These are the key points I would like you to get from this presentation, and I hope I've given you a decent overview of deep brain stimulation and the benefits that can really be enjoyed by your patients. There's no benefit in waiting. Once the diagnosis is confirmed and that it is idiopathic Parkinson's disease and they are levodopa responsive, they will likely benefit. It'll improve their quality of life, and you're just buying them more time with DBS. is opening new therapeutic possibilities, enabling neuroscientists to obtain direct measures of cellular activity. And the mechanism of action of DBS at the cell, molecular, and systems level are poorly understood. Much work remains to be done, but we've made incredible progress over the past, I would say even the past 5 years.